Hi everyone. In this video, I'm going to talk about disorders of primary hemostasis. So, in the last video, I talked about hemostasis and the stages of hemostasis and how the primary hemostasis is the one which involves the platelets, and secondary hemostasis is the one which involves the coagulation cascades, which could either be extrinsic or intrinsic. And then we have fibrin stabilization going on with the help of factor 13, and then the last stage, which is fibrinolysis. Once the healing has started, the clot starts to dissolve. Now I'm gonna go in the division of the bleeding disorders. It could be either primary. So the primary hemostasis has some disorders which would be disorders of the platelets, that might include ITP, TTP, and we would have some more in the upcoming slides. Other than that, we have coagulopathy. Coagulopathy is also named as the secondary hemostasis. So bleeding disorders for the secondary hemostasis are the ones including hemophilia and vitamin K deficiency. And then we'll have some mixed disorders in which there will be problems going on in the primary hemostasis as well as the secondary hemostasis, which are the mixed ones: von Willebrand disease, liver disease, and DIC. So starting with the primary hemostasis. So primary hemostasis is the one in which we are talking about the platelets, right? So the platelet plug is inadequate, and our formation is inadequate. So it could be because of the disorders of blood vessels, or maybe because of platelets. So blood vessels would be vascular disorders of platelets, and then disorders which might include von Willebrand disease. Uh, von Willebrand von Willebrand disease would present with problems in the secondary hemostasis also, but it also presents with the problem of primary hemostasis, which is the formation of the platelets. So let's quickly go through this chart. Problems with the platelets. If we could have two types of scenarios. The platelet count is totally low, which is also called as thrombocytopenia, and then we can have some normal platelet count, but there is platelet dysfunction going on. Platelets are normal in the quantity, but the quality is the problem. So it could be either hereditary or acquired. The hereditary ones are Bernard-Solier, which is an autosomal recessive syndrome. And what happens in this one is there's this receptor on the platelets, which is glycoprotein 1b, which helps adhesion of the platelets with the von Willebrand factor, and then to the exposed endothelium. So this in this syndrome, there is deficiency of glycoprotein 1b, which would lead to low adhesion of platelets. In this scenario, we'll find large platelets. Bleeding time would be increased also, and it would have same features like the primary hemostasis problems, which is mucosal bleeding, and that might include nosebleed, menorrhagia, and stuff like that, GI bleed. So the ones in which we read about the primary hemostasis right here, the superficial, mucosal, nasal, gingival, vaginal bleeding, and the skin bleed. So this happens here in the platelet adhesion problems. Then we have Glanzmann syndrome. In Glanzmann syndrome, we have deficiency of glycoprotein 2b3a, which helps with the aggregation of the platelets, the clumping of the platelets. So because of this deficiency, we'll have less aggregation. We'll still have nasal bleeds and menorrhagia. Those would be the clinical features. On the blood smear, we would see no clumping of platelets in Glanzmann syndrome, and that is an autosomal recessive disorder too. These are the hereditary ones. There's one more hereditary one, which is called as Wiskott-Eldridge. There's a problem in VAS gene, and it presents with immunodeficiency, eczema, and decreased platelet activity. So platelet quality of the platelet is decreased, so function of the platelet is decreased. So this is Wiskott-Eldridge triad of immunodeficiency, eczema, and decreased platelet. Other than that, we can have platelet destruction, which could be acquired from the drugs like aspirin, alcohol, NSAIDs, and then uremia or chronic renal failure, myeloproliferative disorders. Talking about low platelet count, thrombocytopenia. In the first place, the platelets are not being produced in an appropriate amount. So there is a decreased production, which we call as aplastic anemia. It can happen in leukemia too, if the patient is having chemotherapy, and it can also happen in sepsis too, because there will be bone marrow suppression. So there will be decreased production of the platelets. Other than that, there could be another scenario in which the platelet count is low because of increased destruction. Platelets are being destroyed more and more, like in ITP, TTP, HUS, and HIT. Third scenario would be sequestration, that the platelets are like hidden somewhere, like if in splenomegaly, in the case of splenomegaly, and in the case of portal hypertension, platelets tend to move there, and in the splenomegaly case, platelets tend to hide there, so that would decrease the platelet count. We read about the normal platelet count, who we know that von Willebrand disease would have both. And then we have vascular. Vascular might include hereditary, which is Osler-Weber-Rendu, and connective tissue disorders. And then there could be acquired too, like purpura simplex, which includes easy bruising, senile purpura, dysproteinemias, HSP, scurvy, Cushing's, infections, and some drugs. So these are some vascular problems, which is not our main focus right here. We are talking about bleeding disorders, and in primary hemostasis, we are going to talk about the ones which have the problems, the abnormalities is present. The abnormality is present in the platelets. It could be either more and less production of platelets. It could be either more and more destruction of platelets. So we're going to start with ITP, immune thrombocytopenia. In ITP, features ITP can be present. ITP can present in childhood as well as in adulthood. So in childhood, the peak age is 2 to 6 years, and in adults, there's ITP around 20 to 40 years. And in adults, females tend to have more prevalence. Yes, females tend to have more prevalence in adults, but in children it's equal. And in children, mostly children, the ITP usually is preceded by an recent infection. So ITP basically follows a recent infection. And then duration, in childhood it's usually weeks, in adulthood months to years, and childhood spontaneously resolves, but in adulthood it doesn't really resolve spontaneously. So what happens in ITP, it is immune thrombocytopenia, right? And ITP is idiopathic thrombocytopenic purpura. Idiopathic would, it literally means that it is the diagnosis of exclusion. When you exclude everything, then you can think about ITP. So there is primary ITP, isolated thrombocytopenia with no other cause of thrombocytopenia, and platelets would be less than 100. And then there will be secondary thrombocytopenia associated with any other condition like HIV, HCV, SLE, CLL, or it could be drug induced also. In drug induced, there would be antiplatelet antibodies, and there would be platelet destruction, and thus decrease in platelet levels. So you will classify primary ITP on the basis of the diagnosis. If it has been 3 months from diagnosis, it would be acute. If 3 to 12 months, it will be persistent. If more than 12 months, then we'll call it chronic. And if it still happens post splenectomy, then that is refractory. And how does it work? What's the pathophysiology? An acquired immune-mediated disorder, increased platelet destruction, anti-platelet antibodies. What do they do? They just bind to the platelet surface and then increase the splenic clearance, and impaired platelet production. So it could be either the production is impaired or the destruction is increased. So how would you describe the clinical features? It could be asymptomatic too. It presents with fatigue, minimal bruising, mucocutaneous bleeding, like purpura, ecchymosis, petechiae. So what is purpura? Purpura is like occurs when small blood vessels leak blood under the skin. So this is purpura means that small vessels are leaking under the skin, and it ranges from 4 to 10 millimeters. If it is less than 4 millimeter, we'll call it petechiae, and if it is more than 10 millimeter or more than 1 centimeter, we'll call it as ecchymosis. And it can also present with continuous epistaxis, menorrhagia, and intracranial hemorrhage. The blue highlighted part, major concern is spontaneous intracranial hemorrhage, more commonly in elderly. So ITP, whenever you're thinking of ITP, do think of intracranial hemorrhage. How are you going to investigate it? In the primary hemostasis problems, we just know that the platelet count would be decreased and bleeding time would be increased, but PTT would be normal because it is not a coagulopathy. It is not involving the coagulation cascade. So there would be thrombocytopenia, decreased platelets, and we can also see giant platelets. And then we have to go to rule out the secondary causes, that if ITP is secondary to something, so we have to rule out HIV, HCV, H. pylori. We're going to go and test B12, ANA, complement levels, APLA, antiphospholipid antibodies, and then blood group also, RSD typing, and then bone marrow aspirate and biopsy. Because in ITP, we'll see increased number of megakaryocytes. So a bone marrow aspirate and biopsy should be considered pre-splenectomy also, or if there's a suspicion of diminished bone marrow function, that we see some systemic symptoms. So how are we going to treat ITP? We don't really treat if the platelets are more than 30,000, unless there is some active bleeding going on or there was some trauma or surgery. So platelets of more than 30,000 are rarely indicated. Emergency treatment includes means when there is active bleeding going on, either in CNS, GI, GU, or they are in need of emergency surgery. Then we go for emergency treatment. Otherwise, we also have some non-urgent treatment too. So these are two different types: emergency treatment and non-urgent treatment. In emergency treatment, we will take some general measures. If we are taking any drugs that reduce the platelet functions, we are going to stop those drugs. We're going to control our blood pressure and try minimizing the trauma. We can go with corticosteroids, IV immunoglobulins, and platelet transfusions. So corticosteroids like dexamethasone and then IV immunoglobulin can be given with corticosteroid for a rapid increase in the platelet count. So we can give both of them together too. An antifibrinolytic, which could be the aminocaproic acid or tranexamic acid, they can also be used to control some kind of mucosal bleeding. We'll see these the tranexamic acid in almost all the bleeding disorders, because what it would do is the fibrin, if the fibrin is once formed right here, then antifibrinolytic would just stop the lysis of fibrin. So it would just stop the breakdown of fibrin back to fibrin degradation products and D-dimers. So it will just help maintaining the fibrin and maintaining the clot. So tranexamic acid for mucosal bleeding, and then we can also for refractory, or if there is major bleeding or need for urgent surgery, these major things we can give some platelet transfusion, and we can also go for emergency splenectomy. So in ITP, remember, emergency splenectomy may be considered, but before that you have to give antibiotics and vaccinations for against strep pneumoniae, Neisseria meningitis, and HIB, Haemophilus influenza type B. And if in case we have some intracranial hemorrhage, intracranial bleeding, we're going to go with IV steroids, IV immunoglobulins, and platelet transfusion. So this is the major treatment pattern of ITP. We go for corticosteroids, IV immunoglobulin, and platelet transfusion. We can also think about emergency splenectomy. And in non-urgent treatment, the platelets are less than 20 to 30,000, but there's no bleeding, because usually the bleeding occurs when the platelets are less than 10,000, then the patient starts to bleed. But if it's between 20 to 30,000 and there's no bleeding, then that's non-urgent. We can give first line. We can go with dexamethasone, like corticosteroids, or prednisone. So corticosteroids, and we can either go with IV immunoglobulin, or we can, if the patient is Rh positive and they are non-splenectomized, and they still have their spleen, then we can also give NTD for RH positive. That is why we got that RH blood group test also. And second line, we can go with splenectomy, but don't forget giving vaccinations prior to splenectomy, and not preferred if within 12 months from diagnosis. So if it has just been a year after diagnosis, like persistent, we divide it as persistent. Where did it go? Yes, persistent primary ITP. So we do not really prefer splenectomy that soon. We gotta wait. And then thrombopoietin receptor agonists like romiplostim. These are not very commonly used, but these are some TPORA, thrombopoietin receptor agonists. So these will help with thrombin production and thus increase the clotting. And then there's third line, and we can also try rituximab. And then there's third line, which is immunomodulating therapy and psych inhibitors, which would block the platelet clearance. So non-urgent treatment, first line corticosteroids, IV immunoglobulins. Then we can also think of splenectomy, and then TPO receptor agonists, and then some immune modulating therapy like azathioprine. Um, Risk of mortality from bleeding or infection increases with advancing age. So prognosis 20% will not attain a hemostatic platelet count after first and second line therapy. There is a fluctuating course, but the risk of mortality from bleeding and infection increases with advancing age. So this was ITP, right? This is the diagnosis of exclusion. Things to remember is it usually follows a recent infection, and then PTT is normal, and the treatment is important. Moving forward, we're going to talk about TTP, so which is thrombotic thrombocytopenic purpura. It's not idiopathic now, it's thrombotic. So there would be formation of thrombus in it, right? What's the pathophysiology behind it? What happens is the von Willebrand factor, it is secreted from endothelial cells and platelets, and it basically polymerizes. It is present in monomers, in dimers, and in polymers, like in multimers, right? So the large von Willebrand multimers are not active, and there's this ADAM TS13 protease which would cleave the large von Willebrand factor multimers, and then make them for some use, right? But sometimes what happens is, if it is congenitally decreased ADAM TS13, then that is congenital TTP, because there is genetic deficiency in the ADAM TS13. But sometimes it could be acquired too, but which is more common. So more oftenly, the ADAM TS13 is not deficient. The body produces antibodies against it. This is acquired TTP, and that's most often. So without ADAM TS13, the von Willebrand factor is uncleaved. It continues to promote platelet adhesion, because these are big multimers, and the platelets just get sequestrated in them. They get attached to them, and then there's thrombus formation. And because of the thrombus formation, there's depletion in the platelet count roaming around in the serum. So there happens aggregation in the small blood vessel, and that's why it's called thrombotic. But still, the platelet level in the circulation is decreased, so that's why it is thrombotic thrombocytopenic. And with that, what happens is these blood vessels would have the von Willebrand factor in it, and then platelets get attached to it, and then there's formation of plaque. And then what happens is, unfortunately, the RBCs which try to pass through these would get destroyed, and they would form schistocytes of some shape like this, because they get destroyed. And that is why it also presents with hemolytic anemia, which is microangiopathic hemolytic anemia. And in TTP, because the small end vessels are being plagued and small blood vessels are being there's aggregation of platelets and they are being occluded, then there are some neurological symptoms also, like headache, confusion, focal defects, and it could also be presented with seizures, so because the small blood vessels are blocked. And then there's a little bit of kidney dysfunction too. It's not that profound as compared to hemolytic uremic syndrome, HUS, which we'll compare in a while, but still there is neurodysfunction too. I mean kidney dysfunction too. So TTP, the mnemonic to it is the terrible pantad. We'll find fever, decreased platelets, because all of them are used in the thrombus formation, anemia, neurological symptoms, and kidney dysfunction. So it is deficient. It could be either deficiency of ADAMTS13, which is congenital genetic deficiency, and it could be either acquired by drugs, malignancy, transplant, and it could be the HIV associated too. Immune form presents predominantly in adults. So immune form, which we just read, the acquired one, and then the congenital form presents predominantly in children. We discussed about the clinical features. In investigations, we're going to go with CBC and blood film. Of course, this involves the destruction of the absence of ADAMTS13, and then because of that it doesn't have von Willebrand factor, and then because of that there is no platelet adhesions. There is a lot of plaque formation, but the platelets get decreased in the circulation, so there is decreased platelets, and then because of the plaque formation, RBCs passing through it would have increased schistocytes. The RBCs would be destroyed, but the PT, PTT, fibrinogen, all of these levels are normal because it has no problems with the coagulation cascade. At this point, this TTP differs from the disseminated intravascular coagulation, because in that, as its name indicates, there is coagulation as well as fibrinolysis going on. So that is basically in that all of the lab results would be abnormal. So there would be increased PT and PT2. We're going to read about DIC just after this so that we can compare both of them. So yeah, right here in DIC, there is thrombosis as well as hemorrhagic signs. So it's basically combination. There's the definition says excessive dysregulated release of plasmin as well as thrombin. So thrombin would increase the intravascular coagulation and plasmin would increase the fibrinolysis. So basically on the whole, we are just being depleted of platelets, coagulation factors, and fibrinogen. So on the whole, we are being depleted. We are also having a loss of platelets and also having loss of coagulation factors. So both the sides, that is why it is mixed. So both the sides, your abnormalities in both primary and secondary homeostasis. So this is the difference in DIC and TTP, that in TTP, PT and PTT levels would be normal, not prolonged. And in DIC, PT and PTT would be prolonged. Otherwise, just like in DIC, over here thrombosis is happening, and thrombocytopenic platelets are also being decreased. But over there in DIC, clotting factors are also being decreased. And we can also find some markers of hemolysis, like increased unconjugated bilirubin, increased LDH, and decreased haptoglobin, because there's so much of hemolysis going on. And now with this difference of PT-PTT, we differentiated from DIC. Now with creatinine and urea, the renal function test, we are going to differentiate TTP from hemolytic uremic syndrome, because hemolytic uremic syndrome, just like its name says, hemolysis, uremia. So uremia is the kidney part, right? So kidney part, uremia would be like increased creatinine, increased urea in the serum. So uremic, it would have acute kidney injury. And HUS is basically presented in children with some GI illness going on. They would present with bloody diarrhea, or they would present with acute kidney injury. So it is basically like TTP, but the TTP is going on in kidney. You could just say that the TTP, the thrombotic thrombocytopenic purpura, is going on within the kidney. So there is acute kidney injury, which I've highlighted in purple. So creatinine and urea will follow the renal function. TTP has nearly no kidney injury, but HUS or the drug mediated TTP would have increased severe injury of kidneys. And then we can also test ADAMTS13 gene, its activity and inhibitor testing also. Now, how are we going to manage TTP? In ITP, we give corticosteroids, IV immunoglobulins, and then we can also go for splenectomy, right? But TTP, the terrible pentad, is a medical emergency. So TTP is a medical emergency, and first of all, we'll go with plasmapheresis, which is also called as plasma exchange, because we would need to give more platelets, and it could be given with or without steroids. But we don't go for plasma transfusion. Plasma transfusion is usually avoided unless there is some life-threatening bleed going on. So we'll just go for plasmapheresis, plasma exchange, and we don't give antibiotics in TTP. So in plasmapheresis, the plasma exchange which we are giving, we can give FFP, fresh frozen plasma, and we can also give cryosupernatant, not cryoprecipitate, which is because it is rich in fibrinogen. We are not giving cryoprecipitate, we are giving cryosupernatant. So TTP treatment would be plasmapheresis with or without steroids, and don't give antibiotics to them. They would have fever too, so we can also go with supportive management. Mortality is pretty high. TTP mortality is almost 90% if you are untreated, if it is untreated. So it is a medical emergency. Take it as a medical emergency. And HUS, as we said, that is predominantly in children, and in elderly, there's a Shiga toxin. We could say that we find E. coli secreting that Shiga-like toxin. And do remember the E. coli serotype 0157H7, and there could be other bacterial viral causes too, or genetic causes too, but most of the time it's Shiga toxin, and it presents with severe thrombocytopenia, microangiopathic hemolytic anemia, acute kidney injury, bloody diarrhea, GI syndrome. And it would have similar investigations, decreased platelets, because there is thrombocytopenia going on. And then just remember it's similarly like TTP. Over here too, the toxin, the Shiga toxin, there is a toxin mediated hemolysis and destruction of platelets too. So thrombocytopenia and hemolysis, both of them would be same. So we would find increased bilirubin, decreased haptoglobin, and increased LDH, because hemolysis is going on, and decreased platelets and increased cystocytes. And PT-PTT would be normal because there is no problem with the coagulation cascade. But creatinine and urea, the renal function would be abnormal here, and bloody diarrhea. So in this, we just go for supportive therapy. We give fluid, we can give RBC transfusion and nutrition. There is some evidence for plasma exchange also, but there is possible role for eculizumab too, for the neurological symptoms. But we can think of plasma exchange just like we are doing it in the TTP, but we do not give antibiotics, because antibiotics would lead to more and more toxin release out of those bacteria. So we are not giving antibiotics. All right. This was TTP, HUS. Now I want to do DIC, and then I'll move further. So we have von Willebrand disease, which is mixed, primary and secondary both. And actually DIC, to which I'm going to transfer, is also mixed, primary and secondary homeostasis, hemostasis both. But the disorders of secondary hemostasis, which are specifically secondary hemostasis, specifically coagulation cascade associated, that would be hemophilia, because this is factor A deficiency, hemophilia A. And then hemophilia hemophilia B, factor 9 deficiency. And then there's hemophilia C, which is factor 11 deficiency. So these are specifically secondary hemostasis problems. And then we have vitamin K deficiency too, which is specifically more towards secondary hemostasis problem too, because vitamin K would be producing the factors 2, 7, 9, and 10. And I would say 2 is common, but 7 is the one which is in the extrinsic pathway, the smaller pathway. So and then 9 is in the intrinsic 2 and 10 is in the intrinsic 2. So it is like 9 and 10. No, so 10 is common and 2 is common and 7 is in the extrinsic one. It's just 9 which is in the intrinsic one. That's why the extrinsic one is bothered more in the vitamin K deficiency, and that is why PT, the extrinsic one, is more elevated. It is elevated out of proportion to elevation of the PTT. But either way, talking about all of these factors too, either way it is more towards the coagulation cascade and rather than the platelets. So this is secondary hemostasis. Vitamin K deficiency would be secondary hemostasis, and but DIC would be mixed. So DIC is mixed. Von Willebrand factor is mixed. It includes both the problems and liver diseases, liver deficiency. This liver disease, it is mixed too. So let's quickly go through DIC. It is mixed, and what happens in DIC is, damn, I'm clotting, damn, I'm going out of platelets, clotting factors, fibrinogen, everything. So it is release of plasmin and thrombin both. So there is coagulation as well as fibrinolysis going on. So it is widespread activation of clotting cascade and consumption of platelets and clotting factors. So they are just activating the clotting cascades and consumption of platelets and clotting factors. But do you think what's the first thing? What's the thing which is causing it in the first place? What's the thing? So it could be many reasons. Just like in ITP, we read that it follows any infection. DIC also is always secondary to some cause. It is usually these are some important etiologies. So DIC occurs secondary to any other cause. Omits is the mnemonic for that. Obstetric complications, malignancies, infection, trauma, sepsis or shock, and then there would be snake bite too. So omits, don't forget omits. And then there's some more etiology of DIC too, like antiphospholipid syndrome, and maybe there's some intravascular hemolysis going on which triggers DIC, that all of a sudden the cascade starts being activated, and then there's depletion of platelets and depletion of clotting factors. We are just losing them all. So tissue injury, malignancy, snake venom, fat embolism, aortic aneurysm, liver disease, splenectomy, and hypotension or hypovolemia. So these are some vascular stasis. When the vascular stasis is going on, then DIC can start. Pulmonary embolism and hypoxia and acidosis like situations. So occurs as a complication of many other severe medical, surgical, and obstetrical conditions. It is widespread endothelial damage and extensive inflammatory cytokine release. So DIC is a spectrum which may include thrombosis, bleeding, or both. So it could be either thrombosis prevalent or bleeding prevalent, or it could go hand in hand. Both of them would include. And that's how our treatments are also different. There's some treatment in the bleeding phase and then some treatment in the thrombotic phase. But before going to that, talking about the clinical features, it could be both hemorrhage and clotting. So clotting would be microvascular thrombosis. Let's read some of the clinical features of DIC. When there's microvascular thrombosis, what would be the signs? So if there's some going on, say, neurological thrombosis, then there would be seizures, delirium, coma. And then if there's problem with the skin, then we'd see some gangrene because of thrombosis and infarction, purpura fulminans. And in renal, there would be less P, oliguria, azotemia, more and more urea in the blood, and then cortical necrosis. In pulmonary, there would be acute respiratory distress syndrome. In GI, there would be ulcerations, there would be liver dysfunction. And in adrenal, there will be adrenal failure, and RBC, microangiopathic hemolysis like schistocytes production. So that would be microvascular thrombosis, and there would be hemorrhagic too. So usually it presents, the scenarios which we see would be that the patient is there's blood oozing from puncture sites, there's bleeding from any site in the body, or there is some intracranial bleeding, hematuria. So that's hemorrhagic part of DIC. So this is the most common scenario in which they say that blood is oozing out from the puncture sites. Wherever you had IV lines, blood is oozing out of there. And then it could be gingival oozing or epistaxis and massive bleeding too. So what do you see on the investigations? On the investigations, as everything is low, so every test will be abnormal. If we talk about platelets, there would be thrombocytopenia. If we talk about PTT, INR, all of that will be prolonged. If we talk about fibrinogen is the one which gets converted to fibrin. That would be decreased. Fibrinogen would be decreased because more and more fibrin is being produced, so fibrinogen is decreased. And then and that's partially because there's more and more fibrinolysis too, right? So fibrinogen is getting broken down to it's not it is being converted to fibrin too, but we said that with the clotting, there's hand in hand the process of fibrinolysis. So fibrinolysis would be increased what are FDPs, the degradation products, fibrin degradation products, and increased D dimers. D dimers are very specific to DIC. And then there's short euglobulin lysis times because there's more and more fibrinolysis. So with the coagulation, there's fibrinolysis going on. And there would be low RBCs. We'd see anemia because there's anemia going on, the microangiopathic hemolytic anemia. And then we'd see one Willebrand, I guess, yes, only one Willebrand factor would be normal, right? One Willebrand factor would be normal in this one. And how are we gonna treat? We're gonna treat patients of DIC by, first of all, we'll go for supportive measures. We're going to recognize and treat the underlying disorder, individualize supportive therapy, go for hemodynamic stability, ventilator support, aggressive hydration, because everything is abnormal going on, and RBC transfusion if severe bleed. Now, there could be two phases, a bleeding phase or a thrombotic phase. In thrombotic phase, of course, we're going to go for heparin, low molecular weight heparin, which is preferred over the unfractionated heparin. So thrombotic phase is treated by heparin in DIC. But the bleeding phase, where there's lots of bleeding going on and there's lots of loss, like everything is being lost, we can give everything back. So first of all, try treating the underlying condition, but then platelets were decreased, transfuse platelets, especially when there is active bleeding going on and if platelet count is less than 50. Or if there's high risk of bleeding, there is not any bleeding yet, but there's high risk of bleeding and platelet count is less than 20,000. So we can go for platelet transfusion. And then we can also give frozen plasma in patients with active bleeding with either prolonged PT or APTT or decreased fibrinogen. So any abnormality, if shown there is prolonged PTT or decreased fibrinogen, and there is active bleeding going on, we can give frozen plasma too. And the patients of DICU which require any invasive procedure, we can give frozen plasma to them too. So frozen plasma to the patients who require an invasive procedure. And then we can give cryoprecipitate, which is a fibrinogen concentrate, in the ones who are already going in hypofibrinogenemia. So less fibrinogen, we can go for cryoprecipitate in actively bleeding people. So if they are actively bleeding and their platelet is less than 50, we'd go for this. And even if they're not actively bleeding, they are at high risk of bleeding and their platelets are like less than 20,000, so we'll go for transfusing platelets and fresh frozen plasma and cryoprecipitate. We can also think of PCC, which is prothrombin complex concentrate, if the frozen plasma is not possible. Okay, so this was DIC. Factor levels, we haven't read liver disease and vitamin K deficiency yet, so we're not going to discuss that, but let's see about DIC. So DIC would be having decrease in factor 5, 7 and 8, all the clotting factors. There will be decrease in all the clotting factors, but there is a thing that factor 8 comes from endothelium as well as platelets, so not just from the liver production. So it is still decreased because there is low platelet levels in here. So that is the reason. And then this is the clinical prediction of DIC, the International Society of Thrombosis and Hemostasis ISTH calculator. Presence of an underlying predisposing condition is a requirement. There is some underlying predisposing condition like an obstetric hemorrhage or like any sepsis or snake bite, and then we can do DIC diagnosis if we have 5 or more than 5 points. We'll look at the platelet count, we'll look at the level of the fibrin markers, which is D dimer or FTPs. We look at PT and we look at fibrinogen. So D dimers or FTPs, platelet count, PT and fibrinogen. On the basis of these values, we're going to measure the ISTH score, and if it is 5 or more than 5, then the patient is in DIC. Okay, this was all about DIC. I just don't want to confuse while explaining. Okay, let's go with the table first. Differential diagnosis for abnormal coagulation testing. Increased PT, INR would be the ones which have the problem related to extrinsic pathway, the smaller one, in which there is problems with the factor 7, because there is just tissue factor and factor 7, right? So warfarin, vitamin K deficiency, because it involves factor 7 deficiency or factor 7 inhibitors, and liver disease. So that would be increased PT or INR only, and liver disease would be present in both. So if there is a severe liver disease or severe vitamin K disease deficiency, so vitamin K deficiency from here and the liver disease from here, if it gets severe, then it would have prolonged both of the markers. But increased PTT only would be happening in the problems with the intrinsic pathway, that is intrinsic factor deficiency, like factor 8, which is hemophilia A, like factor 9, which is hemophilia B, like factor 11, 10 is common, factor 11, which is hemophilia C, factor 12, and then heparin, because heparin works by activating the antithrombin 3, amplifying the activity of antithrombin 3. So heparin and DUAX and antiphospholipid antibody, which is the lupus anticoagulant. Just remember this, lupus anticoagulant. Even if in antiphospholipid syndrome there is a state of coagulation, but the lupus anticoagulant in it would increase the PTT. And then there is either it's intrinsic factor deficiency or intrinsic factor inhibitors, like factor 8. And both increased if the common pathway factors are deficient, like prothrombin, factor 2, fibrinogen is deficient, factor 5 is deficient, which is common, factor X is deficient. So both of them would be increasing. Now factor 5 deficiency would increase it. But if we say that, oh, we read disease which said factor 5 gene mutation, the Leiden factor 5 Leiden disease, right? So oh, that was a hypercoagulable state. Then how come in a hypercoagulable state there is PTT prolonged? So factor 5 deficiency would prolong it, but in the factor 5 Leiden syndrome, the factor 5 stays activated for long. It's not deficient, it's the opposite to it. The factor 5 remains as factor 5A for longer and longer, because protein C has to inactivated, and then they are resistant to protein C, so they do not inactivate the factor 5. It is prolonged. That is where it is a hypercoagulable state. That is total different story, but just clearing it over here that factor 5 deficiency would increase both PT and PTT. And liver disease and vitamin K deficiency, if it gets severe, then we'll see changes in the PTT levels also. Factor 5, factor 10, prothrombin and fibrinogen as their deficiency, as well as their inhibitors and excessive anticoagulation going on, then we'll have both of them increased. We got done with ITP, TTP, HUS and DIC. I have a quick picture for that right here. First, I'll go over here, ITP, TTP, HUS, and DIC. So ITP, which we talked, was idiopathic. It was not related to any secondary causes, but it just follows some kind of infections, and it is totally a diagnosis of exclusion. And in that, we just saw that there was immune-mediated or idiopathic thrombocytopenic purpura, that platelet levels were low, and we treated with IVIG, steroids, and we can also go for splenectomy. So that was ITP. So just the decrease in platelets. Then we talk about TTP, thrombotic thrombocytopenic purpura. So there was thrombosis as well as thrombocytopenia. And in that, we remember that in TTP there was TTP is the terrible pentad. There was anemia too. So there's hemolytic anemia too. But in TTP, there were still problems related just to the primary hemostasis, just to the platelets. That is why PT and PTT is not prolonged. So TTP would present with fever, with confusion or seizures or any neurological problem like headaches. And then there would be anemia, there would be low platelets, and a little bit of kidney dysfunction. That would be TTP, the terrible pentad. There would be platelet thrombi formation. And that would be because of the deficiency or the inhibitors against the ADAM TS13. So TTP, TS13. So that's TTP. And other than that, HUS, hemolytic uremic syndrome, would be a child presenting with bloody diarrhea. So there would be some kind of GI illness, and there would be acute kidney injury, creatinine and urea problems would be there, and there would be less platelets. There would be hemolytic anemia too, but there would be there would be no increased PT and PTT levels also. So they would have a pretty much similar investigations, but we'll see more and more kidney injury in the hemolytic uremic syndrome, as its name is hemolysis, uremia. So hemolysis would be anemia, uremia would be creatinine and more and more urea and kidney dysfunction. And then S would be any stomach virus, because it is caused by Shiga toxin, so which is secreted by E. coli. And then we'll have DIC. So in DIC there would be platelet and fibrin thromboi, there would be thrombosis, and there would be fibrinolysis also. So it would have decreased platelets, it would have more and more anemia, and it would have more prolonged PT and PTT, because there would be depletion of clotting factors also. All of the clotting factors, 7, 8, 9, all. This was a quick comparison in this table. And now I have this table too. ITP and TTP. We are going to compare ITP and TTP. So ITP is basically, etiology is that there's autoantibodies against the platelets, especially the platelets receptor, glycoprotein 2B3A. These are IgG antibodies. But in TTP, it could be the inherited, it could be the acquired. In inherited, there would be deficiency of ADAM TS13, and in acquired, there would be inhibitors. And then there would be more and more von Willebrand factor. Or it would be normal because there's multimers of it. So platelet count, it would be decreased in both. Bleeding time, which is similar to platelet count, would be decreased. Schistocytes presentation would be in the one where there is microangiopathic hemolytic anemia, which is just the TTP. So schistocytes and LDH problems and bilirubin problems and haptoglobin problems, all of these anemic problems would not be in ITP. So ITP would not be anemic. TTP would be anemic. So there would be schistocyte production, there would be LDH increase, there would be bilirubin increase, yes, and there would be haptoglobin decrease because it's saturated. And then PT and APTT, there is no problem related to the clotting factors, so normal in both the cases. And in ITP, if there are no symptoms, just watchful waiting. You can go with steroids, IV immunoglobulins, or platelet transfusions. And then rituximab, which is a thrombopoietin receptor agonist. And then we can also think of splenectomy, but don't forget about the vaccinations before that. And in TTP, we'll give plasmapheresis. So it is a medical emergency. We'll go for plasma exchange with the frozen plasma and supernatant, and then we do not transfuse platelets unless there is like life-threatening bleeding going on. We do not really transfuse platelets directly because there was defect in ADAM-TS13, so there was already thrombosis going on. So we are not going to give more and more platelets. We'll just try to do plasma exchange so that it balances, and we do not give antibiotics in them, not even in HUS, not even in TTP. And then we have a quick overview again. TTP, ITP, and DIC. Platelets would be low, but in ITP they would be very low because ITP just has this problem. Hemoglobin, it would be reduced everywhere, but ITP, not in ITP because there would be no problems with anemia. So there is no microangiopathic hemolytic anemia, and hemolysis lab would be normal in ITP. And in the peripheral smear, we'll see schistocytes in TTP and HUS, DIC, not in HUS. We can see in HUS too, but we are not talking about HUS here. But there's large platelets in ITP, so we don't see any schistocytes there. And creatinine problem, that would be in HUS most often. But in TTP it could be mildly elevated. And then PT, INR, PTT, which is the coagulation cascade. So ITP and TTP have no such problems, but DIC would involve all of it, so that would be elevated there. Fibrinogen, similarly, DIC would be the one which involves it, and there would be decreased fibrinogen. And D-dimer, similarly, DIC is the one which would have increased D-dimers too. So D-dimers are pretty specific with DIC. Okay, so these are the primary hemostasis problems, ITP and TTP and HUS. And I read one mixed too, which was DIC. Now I'm gonna go and do von Willebrand disease, which is mixed too. After that, we'll have some secondary hemostasis problems. So what happens in von Willebrand disease? Von Willebrand factor, where is it synthesized? It is synthesized in the endothelium and in the megakaryocytes, unlike the rest of the clotting factors, which are usually present in the synthesized in the liver. This is synthesized elsewhere, like in endothelium and megakaryocytes, and it is present in the platelets and their alpha granules. So it gets released from there too. So and its role of von Willebrand factor is to carry, to chaperone factor 8 around the blood, and that is why it increases the half-life of factor 8, and also it helps platelet adhesion and aggregation. So what I could see till here is it's working with the platelets, and it's working with the clotting factors too. So it is a mixed. It helps in both the hemostasis, primary and secondary. And if there is a disease, it would involve both the abnormalities, primary and secondary, right? So von Willebrand disease is the most common inherited bleeding disorder. It is usually autosomal dominant. If the lady is presenting with heavy menstrual bleeding, or if the lady is presenting with right here, consider von Willebrand disease in all women with heavy menstrual bleeding, or like any postpartum problem, peripartum bleeding. So we're gonna think of von Willebrand disease. So abnormal von Willebrand can affect both primary and secondary hemostasis. And von Willebrand does exist as a series of multimers, as I talked already. So the large ones usually deal with the platelet adhesion and aggregation, and the large and small ones deal with the factor 8. So von Willebrand factor, it also varies with the blood groups. Blood group A or blood group O patients have the lowest of the von Willebrand factors, and it also depends on the pregnancy, on the hormonal medication, and in acute inflammation. So it varies. Its levels vary. Now, if we classify von Willebrand factor, there's type 1, which is the most common, 80% of the cases, where there's problems with the quantity. So von Willebrand factor is deficient in the quantity, there's less amount. But in type 2, there would be problems with the quality of von Willebrand factor, their quality of their affinity with the platelet glycoprotein 1b, because we saw in this diagram that the von Willebrand factor, this one gets attached to the subendothelium, and from where it gets attached to the glycoprotein 1b on the platelet. So there might be a problem with the affinity to the glycoprotein 1b. There might be a problem with the adhesion with each other. The platelet adhesion, there is a decreased affinity for factor 8 because they are carrying factor 8 from one place to another. So this is just the qualitative defect, which is in the 20% of the cases. And then there's type 3. So 1, 2, and type 3, which is severe because there is total quantitative defect. There is zero von Willebrand factor produced, virtually zero, no von Willebrand factor produced. This is the most severe one. And just a second, I had a thing for the most severe one and the treatment. I'm unable to find it right now. Let's see. Okay, so clinical features, there would be bleeding. We'll find about the bleeding history. That's the most important predictor, and then we'll do some bleeding assessment tools like we did already for DIC, and we look for the bleeding history. And there's usually mucocutaneous bleeding, there's easy bruising, epistaxis going on for more than 10 minutes, or heavy menstrual bleeding, peripartum bleeding, post-dental extraction bleeding, excessive post-operative bleeding, and unexplained gastrointestinal bleeding. Right here, that's the thing which I was trying to find. So type 3 von Willebrand disease patients can experience musculoskeletal bleeding too. So because there's significant deficiency in von Willebrand factor, right? There's virtually no von Willebrand factor, then there will be virtually no factor 8 attached to it. So there would be production of factor 8, but as it used to amplify its presence by increasing the half-life of factor 8, then there's like literally very significant deficiency in factor 8, so there would be musculoskeletal bleeding in the type 3, because in type 3 the problem is involving the coagulation cascade, but in type 1 and type 2 it is usually in the platelet adhesion and platelet aggregation problems, right? In type 3 it is in type 3 it involves the factor 8, which is secondary, and thus there would be deep bleeding, like musculoskeletal bleeding, right? Secondary hemostasis problem. Otherwise, in first two types, it is primary hemostasis, right? Because there are problems with, usually most of it, there are problems with the platelets being adhesive and aggregating problems and the quantitative deficiency, right? And family history is also very important, but if there is no family history, that doesn't mean that we're just going to rule it out. However, we're going to investigate, we'll do CBC, platelet count, and then von Willebrand factor. So in this, there are some important tests like von Willebrand factor antigen, which would show us how much von Willebrand factor is present. And then von Willebrand factor ristostatin activity. So ristostatin is a cofactor for von Willebrand factor and the platelet binding. Not the factor 8 binding, but the platelet binding. That determines how well the von Willebrand factor binds to platelet. So if we add some ristostatin in the patient's serum, and then there's the activity, and then there's expected result, the timing is less, then that means then there is problem with the von Willebrand disease, von Willebrand factor, because now it's improving, right? So ristostatin cofactor activity determines how well von Willebrand factor binds to platelets. So if it is decreased, normally in von Willebrand disease, it would be decreased because it's not binding to platelets properly now. So ristostatin activity would be decreased, and then factor 8, we'll calculate that too. That would determine how well von Willebrand factor chaperones the factor 8, and PTT also. There's some further tests which categorize the subtype and type of von Willebrand disease. So for that, we'll go for multimer analysis, ristostatin induced platelet agglutination, and genetic studies. In the investigations, PTT would be prolonged because there are problems with the coagulation cascade, and especially factor 8, which is present in the secondary hemostasis, not the primary one. That is why PTT, because, and then there's normal PT because extrinsic is fine. Platelet count, it will be decreased, can be low in type 2B specifically because that is the platelet regarding related to the platelet. Blood group affects the antigen quantification, it is less in group O. Ferritin, because we have to rule out iron deficiency. Von Willebrand antigen, it is decreased as von Willebrand factor is decreased. Ristostatin activity is also decreased, it is a cofactor, so its activity is decreased because there is no VWF. Factor 8, it could be normal, it could be decreased because it is not being chaperoned by the VWF, and then VWF multimer analysis. So how are we going to treat von Willebrand factor disease? We'll go for desmopressin. Desmopressin is used in the von Willebrand factor disease treatment, and also in the hemophilia treatment. So what happens, what it does is desmopressin releases VWF and factor 8 from the endothelial cells. So in hemophilia A, there is problem with factor 8, right? Factor 8 deficiency, which is exclusively secondary hemostasis. And in von Willebrand, it could be mixed, it could be primary or secondary hemostasis. But the desmopressin, what it would do is it would just release von Willebrand factor and factor 8. So this would help. It would release one, oh, it's written there, release of von Willebrand factor and factor 8 from the endothelial cells, but we have to use it cautious because in children it can cause hyponatremia. So von Willebrand factor disease and the hemophilia are treated with desmopressin because desmopressin releases VWF and factor 8. Other than that, we can go with tranexamic acid as it is an antifibrinolytic. We can also go with von Willebrand factor and factor 8 concentrate directly if desmopressin is unresponsive or clinically ineffective for severe bleeding episodes. So there is severe bleeding episode and desmopressin is not working, we can go directly with the concentrate. Need to monitor VWF and factor 8 levels because very high factor 8 levels can again be prothrombotic and can go in a thrombotic state, right? But right now von Willebrand disease, like it's just bleeding, it's not we're not talking about thrombosis in this one, it's just bleeding, right? Okay, and then we can also talk about the gynecological problems because We read that it is pretty common, considered von Willebrand disease in all women with higher menstrual bleeding. So estrogens have an added benefit to the increasing levels of VWF levels. Okay. I'm gonna move forward with the disorders of secondary hemostasis. The secondary hemostasis is the one which includes the coagulation cascade. There is an inability to form an adequate fibrin clot. It could be either intrinsic or extrinsic. So there would be either disorders of coagulation factors or cofactors, or the proteins associated with fibrinolysis like protein C and protein S. What happens in these disorders? Just like in primary hemostasis, we said that there would be some superficial bleeding going on, and then in secondary hemostasis there would be delayed bleeding. So bleeding would be delayed, it wouldn't be immediate, but there would be deep muscular bleeding and spontaneous hemarthrosis or hematoma formations. So we just classify the secondary hemostasis disorders. Hereditary ones would be the hemophilia A, which is factor A deficiency, and factor A deficiency also include von Willebrand disease, and then factor 9, hemophilia B, and which is also called as Christmas disease, and factor 11, which is hemophilia C. And acquired ones are liver disease, DIC, vitamin K deficiency, and acquired inhibitors against most of the factors, specifically factor 8. So we have a little thing about coagulation factor inhibitor, especially factor 8. There's decrease in activity of the clotting factor, or it might increase the clearance of that clotting factor. Factor 8 is the most common one, which has an inhibitor against it. These are acquired. We acquire liver disease, we acquire vitamin K deficiency. It is usually present in neonates too, because they have a very sterile GI tract, and there should be bacteria for proper vitamin K production. But these are acquired liver disease and DIC. DIC also has some primary component as well as secondary component, and vitamin K deficiency too, but it is properly secondary. Okay, so we're talking about inhibitor against the coagulation factors. So it is most often in malignancy, postpartum, or autoimmune disorders. Similar presentation as hemophilia, similar presentation as factor 8's deficiency itself. We can just distinguish between the deficiency and between the factor inhibitor presence, that if we take a sample of the one in which there is factor deficiency and we just add one-on-one normal plasma to it, where there is deficiency, the PTT would get normal, because now there is some clotting factor present there, and it can start the coagulation cascade. But this is called as mixing studies, right? We read it in the last video too. But if we take a serum and from a person which have inhibitor in them, and then we add 1:1 normal plasma to them, there would be an introduction of the factor 8, but the inhibitor would still be there, right? So the PTT would be still prolonged, or like a little less prolonged, but it would be still prolonged. So how would you treat it? We treat them, the inhibitors, coagulation factor inhibitor disease, we treat them with prednisone. Okay, let's quickly go through the hemophilia A8 factor 8 deficiency. These are X-linked recessive disorders, so they are more prevalent in males, and they present with deep muscular bleeding, deep joint bleeding, hemarthrosis, hematoma. Patient may also have associated HIV/HCV. In investigations, we do CBC. Platelets would be normal, but the PTT would be prolonged, because the 8 factor is in intrinsic pathway, but PT would be normal, which is extrinsic pathway. So extrinsic is normal. What is this? Extrinsic. And we will also see decreased factor 8 because there's clearly factor 8 deficiency. And we will also see von Willebrand factor antigen and ristrostatin activity, just to rule out von Willebrand disease, because von Willebrand and factor 8 are closely related. So as there is factor 8 deficiency too, so von Willebrand factor chaperones factor 8. So we just have to rule out von Willebrand factor disease. That is why we'll test von Willebrand factor antigen and ristrostatin activity testing. And in VWD, it would be decreased. We'll treat them with desmopressin, and we can also give factor 8 concentrate. We can give them, especially if we're as a prophylaxis for the patients who have severe hemophilia A, and it can also be given on demand to treat a bleed. And we can also go for tranexamic acid. We can also go for cryoprecipitate, used in it was used in past as a source of factor 8, but now it's just used as a source of fibrinogen for DIC or massive transfusions, because cryoprecipitate is concentrated fibrinogen. Hemophilia B is factor 9 deficiency, also known as Christmas disease. Clinical and laboratory features are identical to hemophilia, except in place of factor 9 deficiency, factor 8 deficiency, there would be deficiency of factor 9. We'll treat them with factor 9 concentrate, not with desmopressin and antifibrinolytic agents. Factor 11 deficiency is also autosomal recessive, diagnosed in adulthood. There is risk of bleeding. The risk of bleeding correlates with the previous history or family history of bleeding. This is hemophilia C. The treatment would be antifibrinolytic agents or frozen plasma or factor 11 concentrate or desmopressin. Now we're going to talk about vitamin K deficiency first, and then about liver disease, because liver disease is mixed. So vitamin K deficiency is like purely secondary hemostasis. So what happens is vitamin K, the etiology behind vitamin K deficiency would be drugs, just like warfarin, because warfarin is vitamin K antagonist. So drugs, and then antibiotics, they eradicate the gut flora. And the gut flora is pretty important for vitamin K uptake, so it alters the vitamin K uptake. Then with that, fat malabsorption. So there are diseases which have malabsorption, just like cystic fibrosis. There was a scenario that the patient had cystic fibrosis, and they had all the other things like bleeding, and then the clinical features of a bleeding disorder. But cystic fibrosis would ultimately lead to a decreased fat absorption and the fat soluble ADEK vitamins, and vitamin K is one of them. So vitamin K deficiency would be there. So similarly, if there is any celiac disease or disorders of bile or pancreatic secretion, disorders like primary sclerosing cholangitis, primary biliary cirrhosis, or cholestasis, or intestinal disease in which there is fat malabsorption, vitamin K malabsorption, then it would lead to vitamin K deficiency. And in newborns too, because they have sterile gut, and poor diet can also lead towards vitamin K deficiency, like prolonged fasting or starvation, or like more alcohol consumption or biliary obstruction. It is rare because GI bacteria have to produce, they do produce enough vitamin K, but we just don't want our GI bacteria to go anywhere. So this is the vitamin K deficiency etiology. And what happens is vitamin K is involved in the production of factor 2, 9, 7, 10 CS. So 2, 7, 9, 10, and protein C and protein S. So 2 and 10 are common, and then there's left 7 and 9. 7 is in extrinsic and 9 is intrinsic. So what happens is 7 has a rather shorter life than 9. So that is why there's more and more PT which is elevated out of proportion than the elevation of PTT. So decreased factors 2, 7, 9, and 10, all of them vitamin K dependent factors. What we are going to do is just going to hold the anticoagulant. If we're taking anything like vitamin K antagonist like warfarin, we're going to hold it. And if there's no active bleeding, we're going to give some per oral vitamin K. But if there is bleeding, we're going to give vitamin K 10 milligrams IV. So reversal, the vitamin antagonist which they already had, reversal takes up to 12 hours. And if there's some life-threatening bleeding going on and vitamin K antagonist was used, then we can give PCC or FP, prothrombin complex concentrate, or frozen plasma. But PCCs are relatively contraindicated in liver disease or if there was a previous history of heparin-induced thrombocytopenia, because PCC product contains heparin. So be careful that they don't have any problems with heparin. So we can give prothrombin complex concentrate, prothrombin, which is gonna go directly and clot. So prothrombin complex concentrate or frozen plasma if there is life-threatening bleeding and vitamin K antagonist was used, right? Because we have to hold it. Okay. Coagulopathy cause can be blood transfusion. Okay. Coagulopathy, blood transfusion. Okay. So sometimes what happen is there is coagulopathy that when we give blood transfusion or we give some fluids like IV fluids, saline, or we do some packed RBCs infusion, then the clotting factors, the number of clotting factors decrease apparently because there is dilution of clotting factors. So how do we treat that? We give them fresh frozen plasma. Okay. And right here, vitamin K dependent factors, vitamin K antagonists, example warfarin, affect the function of these factors. Donosat, thus protein CNS. PT should improve within the 24 hours of adequately dosed. Just as soon as you gave vitamin K and there was there should be repletion, onset should be in 6 to 12 hours. We said that reversal may take up to 12 hours. So the PT should start to become normal, vitamin K PT. So PT should start to become normal within 24 hours of adequately dosed. If it is not becoming normal, then we have to search for other causes. And they say that do not administer plasma or prothrombin complex concentrates, so FP or PCC, for non-emergent reversal of vitamin K antagonists. So you're not going for non-emergent reversal, just example, outside of the setting of major bleeding, intracranial hemorrhage, or anticipated emergent surgery. These are the emergent ones, right? So you can go and give PCC or FP in here, but outside of the setting of this, don't go for PCC and FP in the case of vitamin K deficiency. Okay. Now we have liver disease, which is mixed, primary and secondary. There is pathophysiology, thrombocytopenia, secondary too. So what happens is liver disease would lead to decreased production of the clotting factors. There would be thrombocytopenia. There would be more like hyperspleen, and the platelet would be sequestrated in there. There would be nutritional deficiency, direct bone marrow toxicity related to alcohol. There would be diminished production from chronic viral infection like HCV, and decreased production of the thrombopoietin also, which helps in the production of thrombin. So there is deficiency in synthesis of all the factors like factor 8, except factor 8, because remember that factor 8 comes from liver and it is also made in endothelium and I believe megakaryocytes. Also made in endothelium and megakaryocytes, and it is present in the platelets via VWF. Let me quickly check that point, because I know that in alpha granules there is fibrinogen and PF4, and in dense ADP and ADP and calcium and serotonin. Okay, so not the factor 8, but yeah, it releases from endothelium too. Okay, where were we? Liver, and there will be diminished synthesis of natural anticoagulants also. In our investigation, we will see primary hemostasis, thrombocytopenia, as well as secondary hemostasis, elevated INR, PT, PTT, and TT. PT more sensitive, but it's all of them, right? PT more sensitive. Why? Because investigations in liver disease factor 5, 7, and 8, right? We have to investigate for factor 5, 7, and 8. Expect decreased 5 and 7 because they have the shortest half-life, but factor 8 will be normal because they or it would be even increased because it is produced in the endothelium. So I'm not sure if it's produced in the liver, but it is in the endothelium and megakaryocytes, right? So 8 would be normal. So what about 5 and 7? Out of these two, 7 has a relatively shorter half-life, and 5 is the one which is common. So this would lead to PT being more prominently elevated, just like vitamin K deficiency. PT is elevated out of proportion, so in liver disease too. But it includes primary and secondary both, because there is thrombocytopenia too, because that would be secondary to, in the liver problem there would be nutritional deficiency. Just the first point, in liver problem there would be hypersplenism, platelets will be sequestrated, there would be chronic viral infections, platelets would be diminished, their production would be diminished, there would be decreased production of TPO, so platelets would have problems, right? So this one is liver, and then we have to just give supportive, and there's low fibrinogen in end-stage liver disease too. We have to go for supportive treatment, treat liver disease, blood products if actively bleeding like FP, platelets, and cryoprecipitate. I believe we have completed the hemostasis, primary and secondary hemostasis. We're left with heparin-induced thrombocytopenia. We're gonna do it later. Yep. Okay, now let's quickly go through this table and then we'll be done. So hemophilia A and B would be primary, right? Would they be primary? No, primary is platelets. P primary, P platelets. S is secondary, and coagulation factor problems. So this is secondary. Von Willebrand disease would be primary plus secondary. DIC would be primary plus secondary. Von Willebrand disease, primary plus secondary, as in primary it has problems of platelet adhesion and aggregation, and secondary as it has problems with factor 8. DIC, it is like complete like coagulation and fibrinolysis going on, so all of the factors would be depleted, primary plus secondary. Liver failure, it is mostly, no, it is primary plus secondary, because it has thrombocytopenia too. We just read the causes of those, nutritional deficiency and hypersplenism. That is why thrombocytopenia, and secondary because loss of clotting factors. But within secondary it would be more towards the extrinsic one, and ITP would be just primary, TTP would be just primary, right? Okay, so the ones with just primary would have problems with the platelets, decreased platelets, and right here decreased platelet, and then von Willebrand disease, it could be normal too, and in liver failure it could be normal too, right? Other than that, no platelet problems, right? And now if we just talk about hemoglobin would be there in anemias, and we read where were the anemias. They were in TTP, microangiopathic hemolytic anemia. They were in DIC. They had the similar anemia, but it wasn't in HUS. No, it was in HUS. Yes, it was, but we don't have it here. But it wasn't in ITP. So there would be decreased hemoglobin in DIC and TTP, because there is, we can just write here, microangiopathic hemolytic anemia. But it could be, anemia could be anywhere in these diseases where there's excessive active bleeding and iron deficiency. Okay. Now the secondary ones. Now we'll make sure we are thinking correctly about the PT and PTT. So the secondary one, hemophilia A and B, that would be factor 8 and factor 9. So that would be mostly the intrinsic pathway, and that would be the PTT, the longer one, so that would be prolonged. Okay. In von Willebrand disease, there would be factor 8 problem and the similar thing. It PT2 could be prolonged, could not be prolonged. So yeah. And in DIC, DIC is both. And in DIC, we have everything abnormal. So both of them would be prolonged, both. And liver failure, we have a primary as well as secondary hemostasis, and like almost all of the clotting factor problems. But we just read that 5, 7 and 8, right? So 5 is common and 8 is from endothelium. Yeah, right here, 5, 7 and 8. So 8 is from endothelium, 5 is common, and 7 is left, so which is extrinsic. So there will be prominent PT prolongation, and PTT could be normal and prolonged, because at the end of the day it's about 7. Liver failure, right? So prominent PT. And vitamin K deficiency has a similar problem too. So that is liver failure. And ITP and DTP would have normal PT and PTT values. So that's how I just had to learn this chart.